Welcome to Outpatient Physical Therapy Considerations for Post-Acute COVID-19, part of the Post-Acute COVID-19 Exercise and Rehabilitation Project, or PACER. This is Part 5, Outpatient Physical Therapy Evaluation 2. Many patients who develop critical illness due to COVID-19 have several comorbidities such as cardiovascular disease, hypertension, obesity, and diabetes. These comorbidities are associated with a higher incidence of myocardial injury, and these patients generally have a poorer prognosis. The myocardial injury can consist of myocarditis, which is an inflammation of the heart muscle, stress cardiomyopathy, where the heart doesn't pump as well, and this is also called Takotsubo's cardiomyopathy, ischemic injury due to lack of oxygen, or systemic inflammatory response syndrome, or SIRS, which is related to the cytokine storm or the generalized inflammation. Arrhythmias may be related to hypoxia or electrolyte abnormalities, or both. The most common seen has been sinus tachycardia, but there has also been atrial fibrillation, atrial flutter, and monomorphic or polymorphic ventricular tachycardia. Patients who had myocardial injury in the ICU would likely have had elevated troponin and/or BNP levels, and those results may be available for review in the patient's medical record. We can also look up any diagnostic tests and procedures that were done in the hospital or even as a follow-up in the outpatient setting, such as EKG to determine heart rhythm, echocardiogram to determine heart function, a cardiac MRI, an endomyocardial biopsy that may have been done if the patient had myocarditis, a cardiac catheterization if the patient was ischemic and being assessed for any coronary artery stenosis. They may have even received a stent. Catheter ablation or cardioversion, which is done mainly to eliminate an arrhythmia, whether it's atrial or ventricular, or the patient may have had a pacemaker or ICD, which is an internal cardiac defibrillator, placed due to a persistent arrhythmia. Some medications to note are in the right-hand column with some examples, some example names of some of them, but patients may be on an aspirin, a beta blocker such as metoprolol, ACE inhibitors or angiotensin receptor blockers for blood pressure control, statins, which lower cholesterol, such as atorvastatin or Lipitor, nitrates or isosorbide Imdor, which help dilate blood vessels, and antiarrhythmics, such as amiodarone. Some key cardiovascular points to keep in mind in the outpatient setting after a patient has had COVID-19 is that it's important to monitor vital signs during every session at rest, during activity, and post-activity to assess for any cardiovascular response and activity tolerance. There may be drastic changes with position change for patients or during activity, and it would be important to record that as well as associated symptoms. Additionally, patients are likely deconditioned after a prolonged hospital stay, dehydrated, hypovolemic, anemic, and/or taking new cardiac medications after hospitalization. So it would be more important to monitor their vital sign response. They may have possible myocardial injury and/or additional arrhythmias due to the effects of COVID-19, so monitoring for those changes is important as well. They may have possible cardiovascular disease or risk factors for cardiovascular disease such as hypertension, diabetes, obesity, hyperlipidemia, smoking, and elevated levels of stress, anxiety, and depression. And if the patient had lost significant weight during hospitalization, which many patients do, their current medication doses or the doses that they were on pre-COVID may not remain appropriate as the patient gains the weight back and resumes the baseline diet, or if the patient continues with their weight loss, they may need medication adjustment as well. For cardiovascular exam, it is important to assess heart rate manually for at least 60 seconds on the patient's initial visit to assess for arrhythmia. If the heart rate is regular, future pulse assessments can be 10 or 15 seconds and multiplied by 4 or 6. But during the first visit, monitoring the pulse for 60 seconds will likely ensure that you do not miss any irregularity in the pulse. At rest, the patient could be tachycardic as well, with a resting heart rate of over 100, and this might be due to deconditioning, dehydration, hypovolemia, or low oxygen saturation, or even anemia. Sometimes when the oxygen saturation is low, the heart rate increases to compensate and to improve oxygen delivery. If the heart rate is elevated at rest or over 100, check the oxygen saturation, and if that is normal, then proceed with caution still, but use symptoms and blood pressure response as guidance. The heart rate should increase linearly with exertion and remain stable with steady state exercise. Since the heart rate should increase with increasing levels of exertion, if the heart rate decreases with increasing exertion, this may indicate an arrhythmia, and if this is a new development, we would stop exercise and contact the referring physician. If it's a known arrhythmia, then we would proceed with caution and use symptoms, blood pressure, and oxygen saturation for guidance. Additionally, some patients who had arrhythmias in the hospital while they had COVID-19 may have been discharged wearing an arrhythmia monitor. This is a single patch or electrode worn on the chest, and it can be worn for between 1 to 4 weeks. This should not interfere with anything that occurs during outpatient physical therapy. We would proceed as usual, and these monitors have a button that the patient can press on it if any symptoms occur, and we would encourage that. Blood pressure should be assessed in sitting and standing, and if a patient complains of any head symptoms such as lightheadedness or dizziness when moving from supine to sit, we should also assess blood pressure in supine first after the patient's been lying still for at least 5 minutes before moving on to sitting and standing blood pressures. Systolic blood pressure should rise with standing and with increasing exertion. Diastolic blood pressure may rise or fall slightly or stay the same. Patients may also have orthostatic hypotension, which is defined as a systolic blood pressure decrease of at least 20 millimeters of mercury, or a diastolic decrease of at least 10 millimeters of mercury upon moving from supine to sit or within 3 minutes after moving from sit to stand. A patient may or may not be symptomatic, therefore it's important to have the blood pressure readings. Many patients after COVID have exhibited orthostatic hypotension, so this may not be uncommon. This may be due to deconditioning, hypovolemia, dehydration, anemia, their cardiac condition at baseline, or any medications that they're taking. It is also important to assess respiratory rate, and a normal respiratory rate is between 12 and 20 breaths per minute. A respiratory rate in a patient post-COVID-19 might be still elevated due to deconditioning, fatigue, ongoing pulmonary impairment, low oxygen saturation, or some other medical conditions. We also want to check the oxygen saturation. Normal would be from 95 to 100% on room air. Keep in mind the oxygen saturation may be lower due to ongoing pulmonary pathology. The patient also in the hospital may have had a pulmonary embolus or pulmonary hypertension during their clinical course, and the low oxygen saturation may still linger into the outpatient setting. A patient may require supplemental oxygen upon hospital discharge to go home with, and may still be requiring it in the outpatient setting as well. A physician's order is required to give supplemental oxygen in the physical therapy clinic unless a patient uses and brings their own portable device. When getting a physician's order, it should state a goal of a specific oxygen saturation to keep at or above, which allows the physical therapist to change the oxygen flow based on any activity demands. For post-COVID pulmonary pathology, there are some key points regarding pneumonia and acute respiratory distress syndrome. Patients who had COVID-19 and were in the ICU may have sustained prolonged lung damage that may negatively affect other organ systems. They may have had hypoxemia and/or pulmonary infiltrates, and those gradually improve, but it can take over weeks to months. So depending on when the patient presents to outpatient physical therapy, we may still be seeing effects of the hypoxemia or the pneumonia, such as low oxygen saturation, ongoing dyspnea, and/or increased respiratory rate. If the patient was on prolonged mechanical ventilation, the healing process of COVID-19 and the acute respiratory distress syndrome causes fibrous changes in the lung parenchyma or the lung tissue, resulting in stiffer lungs and a more restrictive breathing pattern. So the patient may not be able to breathe as deeply as they did pre-COVID, and to compensate for this may be breathing more rapidly with an increased respiratory rate. The patient may have also had pulmonary hypertension while hospitalized, and if this is ongoing, that may also contribute to any shortness of breath that the patient complains of. And finally, the patient may continue to require supplemental oxygen after discharge, and this is something that physical therapists have a role in determining whether or not oxygen needs to be increased or decreased over time. There are some important pulmonary diagnostic tests that may be in the patient's medical record and available for review, such as a chest X-ray and/or chest CT, and these would assess the degree of pneumonia and the degree of resolution over time and may continue to be done in the outpatient setting serially. The patient may have had a bronchoscopy while hospitalized in the ICU, which is a test to view the airways. They may have also had a right heart catheterization, which assesses right-sided heart pressures as well as pulmonary pressures, and this is helpful in the diagnosis of pulmonary hypertension. Additionally, pulmonary function tests would help assess lung volumes and flows and may also be done in the outpatient setting. For medications, inhaled medications are preferred over nebulizers to avoid aerosolizing, and patients may be continuing to be on inhalers into the outpatient setting for their breathing. In the hospital, they may have been on pulmonary vasodilators, such as nitric oxide or prostacyclin, but these would have been investigational only as part of a trial and not continued into the outpatient setting. Antibiotics are generally not used unless the patient had a concomitant bacterial pneumonia on top of the COVID virus, and glucocorticoids are not typically used unless there are other indications such as a COPD exacerbation due to the COVID virus. Our pulmonary exam consists of assessing posture, as weakness and fatigue will likely make a patient prone to forward head and shoulders and a kyphotic posture. Increased thoracic kyphosis and/or scoliosis limits lung expansion. We also want to assess breathing pattern. A possible restrictive pattern and/or an increased respiratory rate may occur due to the fibrotic nature of lung healing. This, in combination with posture changes, can make a patient's breathing much more of a restrictive pattern and result in an increased respiratory rate and a decreased sensation of the patient being able to take a deep breath. The patient may be using their accessory muscles of their chest and neck more than using their diaphragm or their lateral costal region for breathing. And we may see some compensatory patterns such as tripoding, as you can see in the picture on this slide, leaning forward on any countertops or equipment, accessory muscle use, of course, and/or nasal flaring. All of these compensatory patterns indicate an increased work of breathing or diaphragmatic weakness and/or fibrotic changes in the lung tissue itself. If possible, lung auscultation should be performed to assess lung sounds. After COVID-19 pneumonia or ARDS, it is possible in the outpatient setting that the patient's lung sounds have returned to normal. However, it's still possible that they may have persistent abnormal sounds, such as diminished or barely audible sounds due to atelectasis or shallow breathing pattern, or they may have crackles due to fibrotic changes in the lungs. Cough assessment may be avoided due to aerosolization with coughing, especially if the patient is still positive for COVID-19. If a patient spontaneously coughs, we can determine if it sounds weak or strong and ask the patient about if they feel that it's effective. If a patient complains of a frequent cough with eating or drinking, it may indicate pharyngeal muscle weakness or aspiration, and the patient may need a speech-language pathology consult. Depending on a patient's clinical course with COVID-19 in the ICU, we can see variable degrees of weakness and muscle atrophy during our musculoskeletal and neuromuscular exam in the outpatient setting. A patient may have post-intensive care syndrome, PICS, or ICU-acquired weakness. The diagram on the right shows ICU-acquired weakness in the middle, and the top of the picture shows factors that contribute to the development of ICU-acquired weakness, where the 5 boxes at the bottom show the consequences of ICU-acquired weakness into the long term. So depending on our patient's presentation, our musculoskeletal and neuromuscular exam may consist of posture, active range of motion, strength and manual muscle testing, checking deep tendon reflexes, assessing respiratory muscle strength or maximal inspiratory pressure and maximal expiratory pressure, assessing sensation, coordination, balance, and gait. There are many functional outcomes measures that can be used on each patient. For strength, there's the options of handheld dynamometry or grip and pinch strength. For lower extremity function, there's a 5-time sit to stand or a 30-second chair rise test. For endurance, there's a 6 or 2-minute walk test or a 2 or 3-minute step test or even a seated step test. To assess balance, we have the Berg Balance Scale, a functional gait assessment, dynamic gait index, the activity-specific balance confidence scale, and single leg stance. And for gait speed, there is a 4-meter walk test. Depending on the physical therapy clinic setting, some tests may be more appropriate to use than others. For example, if clinic space is limited due to social distancing, a 6-minute walk test may not be possible. Therefore, a step test may be necessary instead. Also, it will be important to repeat these outcomes measures over time to gauge a patient's improvement. Some combined outcomes measures include the timed up and go, which is a test for agility and balance, the short physical performance battery, or the SPPB, which assesses balance, gait speed, and the chair stand test, and the senior fitness test, which assesses overall functional fitness, including upper and lower body strength and flexibility, endurance, agility, and dynamic balance. Details on many of these functional outcomes tests and measures can be found on PT Now, which is sponsored by the APTA, or by searching for outcomes measures on the APTA website. Additional measures include the Functional Independence Measure, or the FIM, which can be measured over time, and the SF, or Short Form 36, or RAND 36 Item Health Survey, which assesses general health status. Subjective scales are also important, such as the Borg Rate of Perceived Exertion Scale, or RPE, shown in the upper right, and the Borg Modified Dyspnea Scale, shown in the lower right. Also, a patient may perform the talk test, which means that they should be able to speak in full sentences during moderate level exercise. If a patient can only gasp 1 or 2 words, the exercise is too difficult. And if the patient is able to talk continuously or sing, then the exercise is too easy and it can be increased. Interventions should primarily focus on the patient regaining the ability to perform essential daily activities. This may include employing breathing strategies to adopt a more optimal breathing pattern, such as diaphragmatic or lateral costal breathing to improve depth of respiration, pursed lip breathing to slow the respiratory rate for patients who are breathing rapidly, and possibly incentive spirometry for feedback on increasing inspiration volume. We may also perform range of motion and strength training, respiratory muscle training for respiratory muscle weakness, balance and gait training, and also functional mobility training such as bed mobility, transfers, ambulation, and stairs if necessary, introducing or withdrawing the use of an assistive device, and possibly introducing adaptive equipment for home if needed. Aerobic conditioning will likely be a part of every patient's physical therapy plan. Exercise prescription is important, and we should base the exercise intensity on vital sign response combined with the Borg Rate of Perceived Exertion and/or dyspnea rating on the patient's functional test. In addition to that, we may also calculate an age-predicted maximal heart rate and derive a target heart rate range if the patient is not on a beta blocker. Typically, a target heart rate range for aerobic training is about 65 to 85% of their age-predicted max. If a patient is on a beta blocker, this is going to blunt their resting and their exercise heart rate, and an age-predicted maximal heart rate with a target range will likely not work very well. In this case, we should gauge the intensity and exercise progression by just using the rate of perceived exertion and dyspnea scales, with a goal of a rate of perceived exertion of 11 to 13 or fairly light to somewhat hard in terms of exertion. This would be for moderate level exercise. Of course, you will modify a patient's exercise intensity according to their feedback. For dyspnea, a rating of 3 or moderate would be the highest to push the patient. Keep in mind that patients may require more frequent, shorter intervals of exercise to start. Additionally, supine or seated exercise may be necessary to start if a patient has persistent orthostatic hypotension and does not tolerate upright positioning very well. Starting with supine or seated and progressing to upright over weeks may be necessary. If a patient presents to outpatient physical therapy, still requiring supplemental oxygen, we would assist with oxygen titration at rest and with exercise. As physical therapists, we can increase and/or decrease the flow to maintain the oxygen saturation above a prescribed lower limit. It is necessary, however, to make sure we have a prescription to do so. We would also assess oxygen saturation on a patient's portable oxygen device if they're using that for community ambulation to ensure that they're using the right amount of flow. Other interventions would include safety awareness and falls prevention education, assisting with pacing and energy conservation, such as pairing breathing with stepping or with walking and stairs, incorporating rest periods with activities that cause fatigue, and to incorporate other compensatory strategies. Additionally, we might help with referral to occupational therapy for ADLs, instrumental ADLs, and potentially a driving assessment if a patient has not yet returned to driving and has some impairments. Also, referral to speech and language pathology for any swallowing, aspiration, or speech impairments is also appropriate. Here are some references for further reading on COVID-19 and also on physical therapy functional outcomes measures. And here are some helpful links for further information on exercise prescription and the cardiovascular and pulmonary exam. The PACER presentations by Ellen Hilligus and Morgan Johansson can be found at the YouTube addresses on this slide, as well as clicking on the COVID-19 resources on the Cardiovascular and Pulmonary PT website at www.cardiopt.org. Please join me for the final part of this presentation, Part 6, where I will share my experience at the Boston Hope Field Hospital caring for patients recovering from acute COVID-19.